symptoms. If 6 to 8 hours have passed, the tremors, nausea will be present. If 12 to 24 hours have passed, then alcoholic hallucinosis will be present. If 24 to 48 hours have passed, then alcoholic withdrawal seizures will be present. And 48 to 72 hours have passed after that.
Clear and slow.
Delirium.
You have to be clear and slow. It should be useful for others also. Okay.
Okay. So after 48 to 72 hours after the last drink, the patient might present with delirium tremens. So what do you see in delirium tremens? Visual hallucinations, disorientation to time, place, and person, and disorientation to consciousness, that is lack of consciousness. So you want me to repeat all the questions?
Just go through fast. You can just go through.
Okay, so how do I treat the delirium tremens? I use benzodiazepines, mainly chlordiazepoxide. If there is any liver damage or something, then lorazepam is used. Next, Wernicke's encephalopathy. It's an acute presentation. This is due to thiamine deficiency. So the patient presents with global confusion, ophthalmoplegia, and ataxia. The mnemonic goes by GOA, G-O-A. So global confusion, ophthalmoplegia, and ataxia. The treatment is thiamine. And Korsakoff syndrome, it's a chronic presentation. The patient presents with learning difficulties, confabulations, and amnesia, which is anterograde amnesia. The treatment being thiamine in both of the Wernicke's and Korsakoff syndrome. So next, how do I treat the, to prevent the relapse, I give aversive agents and then anti-craving agents. In aversive agents, I have disulfiram, and in anti-craving agents, such as naltrexone and acamprosate. Should I teach schizophrenia also, today's topic?
Yes, you have to teach today's topic in very,
So that was about the last class. So I just told it briefly. So today we'll learn about one of the important topic in psychiatry, that is schizophrenia.
Your audio.
So schizophrenia is a
Yashasvini, your audio is not very clear. I think you are and the mic is not oriented properly. Your audio is not very clear.
Okay.
Your audio is not very clear. You have to be very clear in speaking.
Okay, today we'll discuss about schizophrenia. It is one of the prototype of psychotic disorders. Is it audible now? Is it clear?
Yes, it is clear now. Better.
Okay. So first, let us discuss about the etiology of schizophrenia. The etiology being, one, there is in the excessive levels of dopamine is present. Along with dopamine, serotonin, GABA, glutamate, ACH, they can also be increased. And in genetic factors, we have higher concordance in monozygotic twins. That is, if a monozygotic twin has schizophrenia, then there are more chances of the other twin getting schizophrenia. And in neuropathological factors, reduction in you see reduction in the cortical gray matter volume and enlargement of ventricles. The other factors include obstetric complications, stressful life events, and advanced paternal age. So this is about the etiology of the schizophrenia. Then what are the clinical features of schizophrenia? So one is the positive symptoms. The second one is the negative symptoms. Then it is disorganization symptoms. Then motor symptoms. And then suicidal thoughts. So what are the positive symptoms that you see in schizophrenia? One is delusion. The other thing is hallucination. Delusion, most common delusion is delusion of persecution. Hallucination, most common hallucination that you see is auditory hallucinations. So positive symptoms include delusions and hallucinations. Negative symptoms, all of which will start from A. So A volition, apathy, anhedonia, asociality, affective flattening, and alogia. Out of which anhedonia is important, that is lack of pleasure in previously pleasurable activities. Then affective flattening is important, that is there is emotional blunting. He'll not have any emotions towards anything. So these are your negative symptoms. So presence of negative symptom indicates a bad prognosis. And then you have disorganization symptoms, disorganized behavior and disorganized speech and thinking, and there is inappropriate affect. Then you have motor symptoms, which is very important, which is also called catatonic symptoms. What are the motor symptoms you see is stupor, that is immobility. Then there is excitement. There is posturing, that is maintenance of a posture for a longer period of time. Then catalepsy, then waxy flexibility. Each of this is important. And then autonomic obedience, negativism, echolalia, that is repetition of the speech. The other motor symptoms include echopraxia, grimacing, and Gagan-Halton, ambitendency, stereotypy, mannerisms, and perseveration. These are your motor symptoms. Just go through it once. Stupor is immobility. Posturing is you're maintaining the same posture. Waxy flexibility is the flexibility when you bend your candle, right? The same flexibility will be present in your movements of the patient. Negativism is purposeless refusal to follow the commands. Even if you tell, he refuses to do it. Echolalia is repetition. Echopraxia is he repeats the same behavior. And mannerisms, spontaneous repetition of same purposeful movements done in an exaggerated manner. So along with that, suicidal tendency is also more. So these are the 5 components of your schizophrenia. So positive symptoms, which includes delusion, hallucination, then negative symptoms, avolition, apathy, anhedonia, and all that. And disorganization symptoms, motor symptoms, that is your catatonic symptoms, and then it is your tendency. So let us solve this question. Because he's afraid of being harmed by his classmates, a 16-year-old kid does not attend school. He believes that his peers make fun of him, gossip about him. He's even afraid of leaving the market. He is most likely suffering with. Is it anxiety disorder? Is it maniac depressive psychosis? Is it adjustment reaction? Or is it schizophrenia? So you see delusion and hallucinations here. He's scared. He thinks that people will harm him. So here the answer becomes schizophrenia. So the following picture describes what sign of schizophrenia. What is it? One of the catatonic symptoms. This is posturing. So whenever you lift his hand or any moment, he will be in that position itself. That is posturing. And then this criteria is very important to call that this is a case of schizophrenia. So according to DSM-5, okay, there will be delusions, hallucinations, disorganized speech, disorganized or catatonic behavior, negative symptoms. So these are what I told you till now. So out of this, at least two symptoms have to be present, and at least one should be present from the first 3. So delusion, hallucinations, and disorganized speech, among this one should be present, and total out of 5, 2 should be present. So this should be present for at least 1 month, and the total duration has to be 6 months. So only then I will call the patient is suffering from schizophrenia. Otherwise, if they don't meet this criteria of 1 month or at least 2 of the symptoms, or at least 1 out of 3, then it will become acute psychotic disorder or delusional disorders. We'll solve few MCQs, then we'll get to know. So this criteria has to be, if you remember this criteria, only then you will call it as schizophrenia. So this question, a 42-year-old man who has been employed by a company for the past 2 years believes that his fellow employees have hatched a conspiracy to get him fired. He believes that they have tapped his phone and that they follow him home. He frequently checks his home for cameras as he believes that fellow employees are keeping an eye. He denies having auditory hallucinations and there are no other symptoms. Which of the following is the most appropriate diagnosis for this man? Is it paranoid schizophrenia? Is it catatonic schizophrenia? Or is it just a delusional disorder or paranoid personality disorder? So you can personality disorder. So, and there are no catatonic symptoms. So I can rule out catatonic schizophrenia. So among A and C, what do you think the answer is? So I'll say the answer to this is delusional disorders because he has the delusions, but will it satisfy the criteria of this? No, it will not satisfy criteria for 1 month and 2 out of this 5. So this will become a delusional disorder, not schizophrenia. Coming to the treatment part, as we all know, there are typical antipsychotics and atypical antipsychotics. So typical antipsychotics are your first generation antipsychotics. Atypical are your second generation antipsychotics. So your this difference is very important. So typical, they act, they are D2 antagonists, whereas atypical, they are D2 and 5-HT2, that is your serotonin antagonism. And effective against is your typical antipsychotics are effective against the positive symptoms, whereas atypical both positive and negative. And extra pyramidal side effects, which is very important, it is more in typical antipsychotics and it is less in atypical antipsychotics. That is why we use more of second generation antipsychotics because they have less extra pyramidal side effects. Then a metabolic side effect, for typical antipsychotics, it is less, whereas for atypical, that is second generation, it is more. This table is important. So these drugs names are again very important. Typical antipsychotics, which are the dopamine receptor antagonists, they can be divided into phenothiazines, thiazanthines, butyrophenones. So in phenothiazines, we have chlorpromazine, trifluoperazine, and thioridazine. In thiazanthines, we have thiazine, flupentazole. In butyrophenones, we have haloperidol and fenfluperidol. These are few drugs, typical antipsychotics, which is again very important. They'll ask direct questions. And atypical antipsychotics, we know it is both serotonin and dopamine antagonists, that is D2 and 5-HT2 blockade is present. So what are the drugs? Clozapine, olanzapine, risperidone, quetiapine, ziprasidone, aripiprazole, zotapine. And the newer ones include the last line which is given, brexpiprazole, cariprazine, pimavanserin. All these are atypical antipsychotics. So these are your typical and atypical. So what did I say? This typical first generation antipsychotics, they'll present with the extrapyramidal side effects. So what are these extrapyramidal side effects? Why extrapyramidal side effects? Because you are blocking D2 in basal ganglia. So that will result in your EPS. So what are these EPS? It will include drug-induced Parkinsonism. These are the side effects of using antipsychotics, EPS side effects. So drug-induced Parkinsonism, acute dystonia, acute akathisia, and tardive dyskinesia. And then you have neuroleptic malignant syndrome and endocrine effects. This is very important. Side effects of antipsychotics. So in drug-induced Parkinsonism, we know tremors, rigidity, bradykinesia is present. So treatment being anticholinergic. So along with the first generation So in drug-induced Parkinsonism, we have tremors, rigidity, bradykinesia, the treatment being use of anticholinergics. So whenever we are prescribing first generation antipsychotics, we also give anticholinergics with them. Then the second EPS, extrapyramidal side effect is acute dystonia. The patient might present with trismus, torticollis, laryngeal dystonia. So again, the treatment for this is parenteral anticholinergics. Then it is acute akathisia, that is inner sense of restlessness, the treatment being beta blockers. Then it is tardive dyskinesia. Tardive dyskinesia is there are involuntary movements of your jaw, lips, and coriform movements, athetoid movements. This is also called rabbit syndrome. Why tardive dyskinesia occurs is this is due to sustained D2 blockade resulting in hypersensitivity. So the treatment being you have to shift to second generation antipsychotics or dopamine depleters can be used. So sustained D2 blockades will result in hypersensitivity causing tardive dyskinesia. Then other side effect is neuroleptic malignant syndrome. Questions have been asked from this. So what do you see in neuroleptic malignant syndrome? You see fever, you see rigidity, you see increased levels of CPK, autonomic disturbances, altered consciousness, tremors, leukocytosis, and elevation of liver enzymes. So why neuroleptic malignant syndrome is occurring? Because you're blocking D2 blockade in corpus striatum, hypothalamus, spinal neurons. So all this will lead to neuroleptic malignant syndrome. So how do you treat? Treatment of NMS is important. So you have to withdraw the antipsychotic, then you have to hydrate the patient, and the drug of choice is dantrolene because to relieve the muscle rigidity, and dopamine agonist can also be used. And again, when will you start the antipsychotic? You have to keep the patient antipsychotic free for 2 weeks, then start with second generation antipsychotics. So this is about neuroleptic malignant syndrome. And the other side effects, the endocrine side effects of your antipsychotics will include hyperprolactinemia. Because of tubuloinfundibular tract involvement, you'll have hyperprolactinemia. And then galactorrhea, menstrual disturbances in females, sexual dysfunction, low libido in males are also seen. Along with that, sedation, orthostatic hypertension might also be seen here. So these are the important side effects you see. Endocrine effects, neuroleptic malignant syndrome, tardive dyskinesia, acute akathisia, drug-induced Parkinsonism, and acute dystonia. Then let us solve this question. A young patient with schizophrenia is intolerant to antipsychotic medications. Which drug is most preferred? Is it clozapine? Is it olanzapine? Is it risperidone or haloperidol? So he's already being treated with antipsychotics, but he's intolerant, so I have to prescribe another drug. That is, the answer to this is clozapine. So let us read about clozapine. So it is the drug of choice for any treatment-resistant schizophrenia. So usually you don't start with clozapine at the starting. It is the drug of choice only when the other antipsychotics don't work. So treatment-resistant schizophrenia, you will give clozapine. Clozapine, it has more affinity for D4 receptors and less affinity for D2. So that is the reason it has minimum extrapyramidal side effects. And there is maximum weight gain, and it is the only antipsychotic with anti-suicidal property. Though it has minimum EPS, we don't prescribe clozapine at first because it has a life-threatening side effect, which includes agranular. Important side effects of clozapine. That is why we keep it at last to prescribe for a patient. So that is why whenever you're prescribing a clozapine to any patient, total leukocyte count and absolute neutrophil count monitoring has to be done. If at all the WBC falls below 3000 per deciliter or absolute neutrophil count falls below 1500 per deciliter, then you have to stop clozapine. So once a week for first 6 months, once in 2 weeks for next 6 months, and once a month till patient continues, the monitoring has to be done. It is a must. So this is about clozapine. So few other MCQs. Which of the following is the most common type of delusion seen in schizophrenia? As I told, it is delusion of persecution, which you see in schizophrenia, most common type of delusion. A 39-year-old man speaks to himself and complains of hearing two people talking about him. On examination, he has reduced affect and impaired judgment. These clinical features have been present for about 3 weeks in the last month. what is your likely diagnosis? Is it schizophrenia? Is it a schizophreniform disorder, or brief psychotic episode, or schizoaffective disorder? So the answer to this is brief psychotic episode, not schizophrenia, because if you see that diagnostic criteria, it was there. So the symptoms should be present for 1 month, right? The criteria which I showed you. So it should be present for 1 month, but here in patient is only for 3 months, 3 weeks. So that is why this will not, this is not a case of schizophrenia. So this will become a case of brief psychotic episode, not schizophrenia. So this is about schizophrenia. So you should know the etiology, and then you should know the symptoms, and then the side effects of each of the drugs, and the criteria to call it whether it is schizophrenia or not.
Okay. Thank you, Yashasvini. That was a very good session. So, both revision of your alcohol withdrawal also and revision of schizophrenia also, she has taught very well. So, I think Archana has to mute herself, I think. Okay, thank you. I think last class we have studied about porphyria. I think today we can solve some questions about porphyria. Okay. So basically you have to decrease reading theory part. So theory part is not going to fetch you anything. Nobody is asking you whether you have read entire schizophrenia. Nobody is asking you to write 10 marks answer about schizophrenia. You write 3-4 points, and then you can fetch you that I have read schizophrenia, or I want marks. That cannot happen. All you have to do is solve MCQs, as many MCQs from as many books, as many coaching institutes as possible. You have to make as many mistakes in as many ways as possible only during preparation. Start reading only MCQs, and retrospectively, whatever MCQs you get wrong, go back to the theory part or the video part, listen to that video and master that part, so that you will not waste time. Okay, am I audible? Okay, so just a minute. Okay, so I don't think anybody will ask you to write any 10 marks question on any topic. So solve as many MCQs as possible, and try to read only those MCQs, those theory part which you get wrong. So last time we had discussed about the porphyrias. So today let's discuss about some of the clinical aspects. So in like any topic which has been already there, like in porphyria, I don't think anything new will come. Everything is already set.